Yeah.
So we are starting with next case.
Thank you so much.
The step is.
Hello.
इधर ले आओ trolley.
This is being seen.
Hello.
You want to show?
No, I don't want to show anything. I just wanted mute so we can take the patient.
Volume down कर.
Hello.
Thank you.
एकदम छोटा कर. थोड़ा ठेव.
7.5 चलेगा.
Hello.
तो देखा patient?
Yes sir, yes sir.
Focus करना. एक जना focus करो. अजय, focus करना. Hello, can you hear me?
Yes sir, we can hear you.
Are you getting the picture?
Yes sir.
Focus करो. Okay, so this is the next case. We have already opened. This is a conductive hearing loss. Again, it is autosclerosis. We can see this is a straightforward situation. I told you we are going to show 3 different techniques today. The next case is going to be done. Ashim is already, through the preparations. That is going to be again an autosclerosis, and then we'll move on to the microtia and chronic ear. So this case, you can see the exposure.
So Satish, we are inducing the microtia.
Yeah, please.
Yeah.
So can you see the exposure?
Yes sir.
See the entire oval window, see the posterior crust, thick posterior crust, the tendon of stapedius, and see the capillaries ascending along the incutostapedial joint. Now,
Yeah, it's an exceptionally long stapedius tendon.
yes, long tendon. Sometimes you find a short tendon, sometimes long tendon. And you have seen last case, the reverse stapedotomy.
Yes,
Here
sir.
I am going to use the CO2 laser. In the last case, you had seen the KTP for the particular purpose of handling the vessels. Here I am going to use the CO2 for the rest of the steps and see the level of the joint first. You saw the Ashish opening the joint in the last case. So how to ascertain the joint? You mobilize in the anterior-posterior plane the long process of the incus and get into the joint directly. That's a very, very important step without traumatizing the lenticular process. And I can see, make this incutostapedial joint absolutely free. Now,
When the length of the stapedius is too long, you can expect the posterior crust to be more vertical and less of an arch. We will see whether that happens here.
see this exactly, Ashish, what you just
Yeah.
mentioned. The posterior crust is like a vertical strut.
It's more vertical, yeah.
Yes, it's not an arch. The
So
reason is the
therefore,
long
the incus
process is,
will be aligned more to the posterior half of the foot plate in this particular case.
yes, exactly. Now, with this laser, again, I have shown multiple times. Why the laser is not coming in the view? Laser.
Hello, best of luck to us all. Don't worry, beta. Don't worry. Yeah.
Light to बंद कर दी?
Right, क्या चला?
Yeah, let me show you the laser beam first.
Ashish sir, we want to see each and every step of the microtia surgery.
Yes, sir. We've also got a lecture in which we will. This is a very, very difficult intubation. We have invited another friend of ours with his flexible scope.
Yes,
The patient is syndromic, so
हिला इसको पूरा नहीं बन रहा, सर्कल नहीं बन रहा.
Adam, can you take the
हुआ?
table down?
Yes, I am just trying to set up the laser. Can you
Yes, sir.
see the laser beam?
yes, very well.
So this is the most simplified version with this laser, which we have already shown so many times. So what I am doing now, first with this beam, I am going to vaporize this tendon. I am not doing a reverse stapedotomy since I am having this laser. So now I have no insecurity regarding mobilization of the foot plate or anything. See this?
Yes sir.
In couple of shots, our tendon is vaporized. Now my next step, you can see the posterior crust like Ashish mentioned. Absolutely vertical. It is not giving appearance of an arch. Now what I'm doing is I'm using the laser to vaporize the posterior crust. Can you see this?
Yes, sir.
करना ऑन कर नहीं चल रहा. Yeah, I am getting the laser beam ready. See this?
Yes.
Vaporizing the posterior crust. This is, I would say, the most simplifying version of the stapes surgery if you have this laser. This is luminous. See, I have already thinned out the posterior crust. See this? It is already broken.
Yes.
Anterior crust is fragile, we know. I can break this and bring out the foot plate, the stapes suprastructure in no time. Can you see this?
Yes, sir.
Forceps. See, it is like a video game, you can say.
That noise.
It is like a video game. And now we have the foot plate in view. Can you see?
Yes,
The
sir.
part of the superior part of the foot plate is thick. But inferiorly in the central part where we have to make the fenestra is very good. Can you see very clear?
Yes, sir. Yes,
At
sir.
this point, I will measure the required size of the piston.
Why have you not given me the proper circular, the diamond?
Ashim,
Yes?
any comments?
No, no, it's perfect. Very good.
Are you ready?
Yes, I'm ready.
Okay, I'll be through in a couple of minutes.
I know.
And see what I'm seeing is the required length of the piston. And the piston I'm going to be using is I've used couple of times the Kurz piston.
Yes, sir. Yes.
And the length I'm looking at is, I'll start with the 4.5 first. I will place this thing. It should coincide with the incus. Can you see?
Yes, sir. We can see.
I will repeat it.
Today people enjoyed the Teflon piston also.
Yes. Now, 4.5,
And then you just
little longer. So I will change to 4.25. Now see, it should coincide with the incus. Now it is perfect. Can you see?
Yes, sir.
So my piston is so 4.25. Okay.
Yes, sir.
Hello.
Now, as I told you, this is like a video game. This is the safest in the beginner's hand, I would tell you, because using this laser is ruled out the possibility of mobilizing the foot plate.
Ashish, sir.
Yes.
Sir, I have a question. Ashish sir mentioned that the piston has to be perpendicular. So there is no particular side for stapedotomy. We need to have a perpendicular piston irrespective of the size of the side of the stapedotomy. Is it true?
No, but generally you have to make sure that it is in the posterior part, because as Satish earlier mentioned, the problem here is that you want to stay as far from the utricle and sacule as you possibly can.
Yes.
Okay.
Now see with my beam, it's a single shot, 20 watt, and it didn't go through. Can you see?
Yes, yes.
Now what are the options with me? To fire again, which I am not going to. Yes, I can fire because it had already thinned out. It is already thinned out. I can fire with a less power, or since it has already thinned out, I can try, using a mechanical instrument to penetrate. Can you see this?
Yes, yes.
This was a thick foot plate which was partially taken care of by
CO2.
the laser, thinned out, and then I could penetrate easily without mobilizing it with my. See this fenestra? My fenestra is 0.6 mm, and my piston, which I am going to use, again is the simplest of the piston in terms of simplicity, in terms of biocompatibility. This is excellent. This is a clipped titanium piston. The beauty is Why I say simple for the beginners, there is no need of crimping. Crimping is an extremely difficult, step in terms of getting an adequate crimping. It should not be over crimping, it should not be under crimping. And in the next case, Dr. Ashim Desai is going to demonstrate you with his superhuman two-handed efforts of his techniques of crimping. That is something he can do, which I can never think of doing that, which he is going to show you. Now see the simplest aspect of piston placement.
Yes, sir.
Oh, just a minute. What I will do, I will place my piston at the fenestra. See the piston at the fenestra?
Yes, sir.
And this is the piston which is going to take on the long presses of the incus. See this?
Yes.
I will ascend roughly, it should be 1.5 millimeter from the edge of the lenticular process. You just simply push. See that?
Yes, yes.
The middle slot of the piston is going to take the long process of the incus. So simple. The best thing is the simplicity of the stapes surgery you can think of. Can you see?
Yes.
Last case we saw a difficult situation of thick foot plate, which Ashish simplified by means of his wonderful, technique of drilling, his expertise. This is a simple situation which is made further simple by the laser. Suppose in this case, I had been facing the same situation like Ashish, I would do the same thing. I would never use the laser on the thick foot plate. I would use a drill to flush the blue foot plate, and then I would use the laser to make a fenestra and use this piston. That would be the only change in the technique. And the last part now, we always use, this is a direct piston technique. What I am going to use is a drop of blood over the fenestra to seal this. This blood contains fibrin, and this is an amazing material to seal the fenestra. Since the vestibule is full of perilymph, this blood is never going to go inside. The vestibule is completely full of, a perilymph, and this is the best sealant, I believe. We never use anything like gel foam or any tissue like fat or anything to seal the fenestra. There is no need. If your piston is of adequate length, you don't need to seal the fenestra at all. In the next case, I told you we have 3 different cases with different techniques. In the next case, we will witness a different technique where Dr. Ashim Desai is going to demonstrate his own is a modification of COS technique with the 0.7 or 0.8 mm fenestra with a Teflon piston with a vein graft, and that will be a amazing demonstration of the vein graft, his classical technique. So this case is over to me.
Yes, sir.
My associate will close the ear, he will put in the gel foam, and I am through the surgical part. So it is so quick. See, the laser makes your life simple, and this is the beauty of the luminous laser, CO2. When we made the fenestra, the foot plate was thick. We used a 20-watt shot. Since it was thick, it couldn't pass through the entire thickness of the foot plate. So, but it thinned out, and then we used the mechanical instrument to, make the fenestra.
Sir, Dr. Krishna wants to know, in the last case, in the obliterated foot plate, can we use CO2 laser?
Yes, I
The
mentioned.
answer is an absolute no.
Yes.
I've
The reason
already
for
mentioned.
this is that when you are having the CO2 laser, you are generating heat on a flat foot plate, on an obliterated foot plate, because too much power is required to penetrate, and then you are literally cooking the labyrinth.
Yes, sir.
The best way, not only labyrinth, you can endanger the facial nerve as well. So the best is flush the obliterative focus or thick foot plate with the micro drill the way Ashish did. bring out the blue footplate, and then you can use the laser for the fenestra. Yes, Ravi?
No, I was just inquiring about this doubt about you using 20 watts on a
20 watts. 20 watts.
and then you used mechanical.
In this case, yeah, the Ravi, I tell you, that's a very important thing. Majority of the patients, when you have a blue footplate, not a thick footplate, you get through with a single shot 20 watt into the vestibule. It takes up the footplate thickness completely in one shot. If you have a thick footplate, suppose this was, my 20 watt shot was not adequate. I didn't want to use more laser energy to endanger the facial now, to produce more heat. There could be micro dehiscence in the facial now where the heat can dissipate. So never use over 20 watt. Now the question was, couldn't I use the another 20 watt shot to go through the footplate? I could. But since I have already thinned out the footplate, my purpose was solved. And I could easily, make the fenestra with my the mechanical instrument with my perforator rather than going through the laser shot again. So the beauty of the laser was,
once the fenestra is made, you never shoot the CO2 laser again.
Never.
Once the fenestra is made, however small.
That's a disaster. If you
Correct.
laserize the open fenestra, open vestibule, then you're gone. Completely gone. Never ever do it. So our philosophy is never use a